Dr. Andrew Rosen. I'm a psychologist.
And I'm Dr. David Gross, and I'm a psychiatrist. And we are two shrinks and a mic.
Thank you for being here today. Today is going to be our special podcast because we have a guest. And our guest is Dr. Celina Moore, who is a pediatrician who has joined as a consultant for the Children's Center for Psychiatry, Psychology, and Related Services. And she's going to be our consulting pediatrician who will be evaluating and sometimes prescribing treatment for children starting at the age of almost 0 and up to age 18. So I'd like to introduce Dr. Moore and ask her to tell a little bit about herself.
I'm so happy to be here, not just here physically right now, but it's just like being with these great minds and this great place where we can help kids. So my name is Celina Moore, and I'm a general pediatrician, and I have been working here in South Florida for over 20 years in all things being kids. And I have recently joined the center, the Children's Center for Anxiety, to really help kids who are struggling. We all know that there's this epidemic of mental health in kids, and we could always go into the causes of that. But the real thing is, how can we help them? And any little part that I can play in that, I'm really proud to do that.
You know, it's our pleasure to have you, and I thank you for taking time out from a busy day and leaving the parents behind and the kids. What I've been most impressed with is your passion and interest in the behavioral aspects of pediatrics, which is unusual. I mean, many pediatricians will end up putting their kids on psychostimulants for ADHD, et cetera, but your interest in all aspects of the emotional, behavioral aspects of childhood is wonderful, and that's why we're so happy to have you join us. Can you tell us how you got interested in the behavioral aspects of pediatrics?
Well, you know, when you're in the medical field and you're going through medical school and you're looking at all of these symptoms, you know, like fever or cough or runny nose or stomach ache, we often gloss over the fact that behavior is a symptom. And because behavior is often viewed as being good or bad, acceptable or not acceptable, we look at the negative aspects of, you know, behavior as something that someone else is doing wrong, right? The child is bad, right? Or the parents are wrong. When really it's just a symptom like fever. And you look for the causes of the symptom. And then once you find the causes of the symptom, you can either do a quick fix or you can, you know, do more supportive care, like fluids and rest in the terms of fever, right? But more of supporting the child as a whole, you know, including the family and the parents, while they either grow out of this or we can modify the behavior in more acceptable ways.
One of the things that I always think about is what's the most common reason why a young child, when they're in school, goes to the nurse's office. And, you know, I guess the predominant percentage is a stomach ache, right? And so the child goes to the nurse's office, and whatever happens at the nurse's office, hopefully that child's tummy feels better and it doesn't happen again. But very often that tummy ache is a symptom of anxiety or fear or stress about being away from home, being in an environment such as the school where there's strangers and there's authority figures, et cetera. So I'm sure you get plenty of calls for tummy aches from parents who will say, well, you know, Johnny has been in the nurse's office for a tummy ache a lot. What would your response be to something like that as a pediatrician?
So as a general pediatrician, we try to exclude the medical part first, right? Does the child have an ulcer or a stomach bug or something that will be self-limited, and, you know, we can have certain measures that we can help them through this. But when we start seeing patterns, and a lot of being a pediatrician is looking, like zooming out and looking at patterns. When we start seeing patterns of belly aches Monday through Friday, or, you know, vague headaches and things that when you do an appropriate workup yields nothing in terms of something physical going on, then you need to dive a little bit more deeply and find out why they're complaining of a stomach ache. And the stomach ache is not fabricated. The stomach ache is real, but what's causing that stomach ache? And a lot of times, depending on the age of the child and their insight, they don't know. They can't tell you like an adult would tell you, well, I'm afraid I'm going to get yelled at, or I'm afraid that, when I get home, something bad's going to happen, or whatever it is. They don't have that insight. And so a lot of it is supporting them until they understand emotions and words and put those two together, because that also is developmental milestone that a child needs to get to, of understanding the emotion and adding the language to that to be able to explain themselves.
In this day and age, unfortunately, mental health issues remain to have that stigma attached to it. And I would imagine that because of your openness to the presence of, anxiety, depression, or behavioral problems in the kids that you see, it allows the parents perhaps to be more comfortable in talking to you about it. Because I'm sure a lot of parents are reluctant to say, my kid needs to see a mental health practitioner, because immediately that means, that kid is sick or crazy, not as good as the other kids. And so I suppose it gives you an advantage in that. When do you make a decision that you need to go beyond the pediatric practice and refer to a mental health professional for problems?
So I know what I know, right? I know my limitations, and I do know that I can have quite a bit of impact in the, beneficial impact in mental health issues with children. So, whether it is listening, that's what the nurse does. She gives the kid ice chips and she listens to them, right? So, whether it's the listening, acknowledging, that's half the battle right there. And
Right.
and giving a kid and a family hope that we will get through this, and I will help you with this. When I refer out is if I am wary of maybe something bigger going on, that a child psychiatrist might need to intervene. If we have a very strong family history of, different mental illnesses, that this might be the initial presentation and this will not be the end of it. Depends on the age of the child as well. But common things are common, and a lot of kids have more of a situational transient anxiety based on, their environment, and equipping them with tools it goes a pretty long way. Yeah.
One of the things that I'm excited about in terms of you being at the practice is that as a pediatrician who has a special interest in emotional and behavioral problems, you're in a better position to end up having an impact compared to the situation where the referral is to a child psychiatrist. It's kind of like it's much more of an extreme referral in the eyes of, I think, of parents and most people. So that area, that interface between normal kinds of issues that children have, the stomach ache, the anxiety, the I don't want to go to school today, may not require anybody having to say, well, your child needs to see a child psychiatrist. That's a big red flag for most people, and scary, and more likely to want to be avoided and denied. But with you as a pediatrician, you're in a position, I think, much better to ameliorate situations that aren't so extreme. And so the target audience is much larger, and I think you can have a greater impact on a much larger population before they get to see such severe problems.
Yeah, I'm never going to knock a good child psychiatrist. You guys help me out so much. But I agree that a lot can be handled by a general pediatrician. Another advantage is that I can look at the child holistically. And what I mean by holistically is look at not just the symptoms of the behavior, but also what we call the differential diagnosis of what else could this be. And then look at the pillars of the child's life and making sure that they are strong and intact, that the foundation is good. If we have a child who has horrible sleep habits, they are not going to have a stable outcome with their depression, for example, or their anxiety, because lack of sleep is only going to complicate things. Or if they are in a situation where the diet is lacking, whether it's not enough in terms of calories or the wrong types of foods, then we're going to see behaviors from that as well. So being able to look at the child as a whole. And another great place is also being in an environment where I've got some great psychologists that are much more skilled than I am in being able to navigate the family dynamics, because the kids don't exist in a vacuum. The whole family needs to be carried through this.
But you touched on the key issue, which is being a good listener. Whether you're pediatrics or psychology or psychiatry, that's half the battle.
Yeah.
And maintaining that connection with the individual is critical. One of the things that I see is, as an adult psychiatrist, is when somebody comes to see me, I have the advantage of having a track record. So if I see, Joe Schmo or Jane Schmo and they're depressed, and this is the 6th depression in the last 15 years, it tells me something about the biology or the family situation or the life situation that created it. But you get to see kind of de novo disorders, a kid who comes in for the first time with school phobia. And I would imagine the toughest thing is to try to differentiate how much of this is just a phase and a life situation from how much of this could be an ongoing difficulty that the child has. And again, my advantage is that I've got that past history, and you've got to be, I guess it's more pressure on you to figure out how much of this is serious or not.
We are really, as pediatricians, the front line. We really are. And it's a very unique position to be in. And it's sometimes a little bit, I don't want to say scary, but I look at it with a lot of respect, because, you have to look at all of the possibilities that are out there and be able to give reassurance to the family that this is a phase or not a phase. But we do a lot as pediatricians in the realm of anticipatory guidance. We expect this outcome. If this doesn't happen, then we're going to look at this. And we're not going to go down that scary what if tree very early on, because there are too many branches in that tree. So we're going to follow this route, and then we're going to follow the trunk, and then where the branches branch off, then we're going to go to the most probable one. And if that's not where this child is headed, we backtrack a little bit and go up another, my little tree analogy.
Mm-hmm. But then you're dealing with the Dr. Googles who get on the website, and the parents find out, say this, that, and the other thing, and they go down that what if tree.
They're already in the canopy. I'm in the part where you can actually start climbing. But experience is very helpful to be able to be able to understand all the players involved, the players being everything in the child's life. And one of the most frustrating things as a student doctor and as a resident physician and as a new pediatrician earlier in my career was when I had people with more gray hair than I did say things like, "Oh, well, I just know." I'm like, how do you know? Right? I wanted that experience, and I really, I have it now. But in the beginning, it was very frustrating to me when I had people who were my mentors just telling me, like, I just know because I've seen this 800 times.
Right.
Yeah.
Well, the new parents are anxious to begin with.
They are.
And I just remember when my first child was born, and my wife tells the story all the time. When he was, I think, 3 or 4 weeks old, he developed a rash. It was in the summer in New Haven, Connecticut. We had an old-fashioned pediatrician who had a herringbone jacket with leather patches on his elbows, and almost smoked a pipe, did his own urinalyses. But Carter Stilson was his name, wonderful guy. But my wife brought our son with this rash, and he looks at my son, examines him, looks at my wife, and said, "What are you doing to my kid?" And my wife shrunk down into the chair.
Bundling him up.
He's got prickly heat. Overdressing him for the weather. But new parents are really anxious. I'm sure now with the internet, they just get on the internet all the time to try to assuage their anxiety.
It must be a good thing for you and the parents, though, because you have a lot of data points and you meet them early on. So they have a relationship with you, and they start to trust you.
Yes.
And if you say something, you're not a stranger.
Right.
That's got to be so valuable.
Right. That's super helpful. And especially when they're on their second or third kid, I spend a lot of time in the beginning of a, doctor-patient relationship with expectations and communication and anecdotes and all of the stuff that's kind of like the dating phase of the doctor-patient relationship. I don't mean that in a creepy way at all. That could totally come out weird. But but in the getting to know you phase. And that way I can see where their sticking points are, and they can understand, I once had a mom who I had called on a Saturday because I was just thinking of their child. And I'm like, I wonder if this is what's going on, in the course of the health of the child. And the mother had, quite a bit of anxiety that I called her on a Saturday afternoon because she's like, well, if you're worried about it, then I must be worried about it. Because you get to know the personality of the person taking care of your kids. And, if they're an alarmist, then it's very easy for the parents to be an alarmist.
No, that's a good point, because I'm thinking about how long it takes us as mental health professionals to develop that trust. And for you, it's just kind of natural because the parents need to have somebody who's an expert who's going to be there and the advocate for them and their child. But for us, many people come in being anxious about what's going on with them in the first place. We're strangers, and it may take months before that trust is developed.
And the only person that maybe has said anything to that parent about their child may be the teacher or the school counselor, bringing up the concept of maybe there's some sort of emotional issue going on. So to hear it there and then not know what to do with it, where are they going to go to find out more? Well, they can go to a stranger or TikTok or you. Yes. And so, you have that trust built up. So, your situation is so valuable in early identification as opposed to early denial.
Right, exactly.
Huge.
Yeah. Well, there's a river somewhere, right?
Right, in Egypt. Speaking of which, one of the things I've learned about you, that's a good segue we didn't realize.
I thought the same thing when you said river.
And Egypt, it's a Nile, and that's a river in Egypt. And I'd like you to tell a little bit about what you do in an area not too far from Egypt.
So let's see how far back to go. When I was about 4 or 5 years old, and my grandmother asked me what I wanted to be when I grew up. And I said, I either want to be a pediatrician in sub-Saharan Africa, because I knew those words at that time, or a waitress. Those were my two career choices at that age. And I've kind of planned my life to eventually go to sub-Saharan Africa and become a pediatrician there. And about 8 years ago, I actually started doing that. My children were in a place that they could be, I didn't have to worry about them all the time. They were already in high school and college, and I had a little bit more flexibility in my schedule. And I started going there first with the idea of wanting to help, wanting to make a difference, wanting to fulfill this lifelong dream that I've had. A parenthesis here, my parents met in sub-Saharan Africa. So that's where that idea came from, and that's where their love story began. And so that's why that area of the world really attracted me a lot, because as a young child, we had all the books and the art and the music and the colorful outfits and everything from that part of the world. So as a very young child, I thought I was actually part African, but now I realize that it's just where my heart was. And so my husband and I went, and we went, he is not a physician, but we went on a medical outreach, and he did his part in the non-medical part of it. And then we decided that we could actually do this. We could start a foundation, and we can plan these trips, and we can actually make a difference. And there's been, there's a learning curve, and there's I could talk about this forever, but I think one of the important things to look at is, there are barriers to care everywhere. My practice is in West Palm Beach. I've practiced in Boca Raton for many, many years. And we don't realize that there are also barriers to care here. The ones in Ghana, which is where we go, are a lot more obvious. And they have a huge sequelae, life or death type of outcomes, because those barriers are so big. And what our project does, what our foundation does, is that we go twice a year. We bring volunteers with us, and we go to the same villages over and over and over again, establishing rapport, following long-term, the healthcare needs of these villages. And then as a pediatrician, my special interest is in the health of children, is helping them not only physically with the recurrent malaria that they may be exposed to, or the anemia because of their nutritional deficits, or just, infectious agents that could take their life before the age of 5, but also getting them academically up to par so that then they can dream big and they can do what they can do. And it's, I'm going to start crying because this is really my happy place. And I encourage anybody who ever had a dream at the age of 4, whether it was being a waitress or a pediatrician in sub-Saharan Africa, just to do it.
What's the name of your foundation?
It's called Acoma M Tosso Foundation, and it means linked hearts. And it's a Ghanaian adinkra, which is like a symbol that almost like, I just did this with my hands, but like a heart, you see the symbol of heart, and you can think of love, and you can think, all those things. They have a whole bunch of symbols. They're called adinkras, and they each have, the word that it is, and then the deeper meaning. So basically the meaning of this adinkra of Acoma M Tosso is it's an understanding across communities. So we are an international foundation. So we are a nonprofit here in the United States and a nonprofit in Ghana. So half of our volunteers usually come from the Guinean population in the area, whether they are doctors or nurses or student doctors or just do-gooders, that they just want to help underserved areas. And so that's what we do.
So people continue your work after you leave for that particular visit?
Yes, we've established a network there of people in the healthcare field who are placed there by the Ghanaian government. They're kind of their posts, whether they are nurse midwives or nurses who deal with vaccine promotions or whatever it is in the area, that they are plugged into these communities where if there is one of our children that we sponsor who falls ill, or if there is someone in need, that they relay that information back to us while we're stateside, and then we help them. The internet is a wonderful thing. We
Celina,
can get things out there.
One of the things that we hear about is compassion burnout amongst physicians and mental health people. And I frequently hear people talk about being tired of giving. And I think it affects, one way or the other, it affects the quality of care that exists in the United States, in our area, where professionals are kind of tired of giving of themselves. You have something exponentially greater in terms of the desire to give. And so I'm curious as to how that affects your everyday giving. It must make it even more joyful.
They say that love multiplies. So I think that's what it is.
Wonderful. That's wonderful. Very special.
I've heard repeatedly from internists and other specialists that it's if they don't get burned out by giving, they get burned out by the obstacles to their ability to give. The physician who has to see so many patients in a day that they can't spend the time with them and do the job they're supposed to do. And I would imagine that you get refreshed every time you head off to Ghana to do your thing there, because it makes it a lot easier than. One of the reasons why we did this podcast is because you have to keep kind of reinventing yourself in a long career, but also it's a good balance with some of the work that we do in our offices as well. But unfortunately, in healthcare in our country, there's so many obstacles to providing the kind of care where we want to provide, whether it be the electronic medical records that are, migraine headaches repeatedly, or the numbers of patients we have to see, or the prior authorizations for medications or insurance forms, or all the limitations on care. It's really difficult. So being able to find ways of giving back, I think, is terribly important.
Right. It's not easy over there. And I do struggle sometimes when I'm there that I just can't do enough, or why does this have to be this way, or the injustice of it all. But I think that I had mentioned earlier barriers to care in the United States, and that is the healthcare system is one of the greatest barriers to care, is the system itself. And it is horribly frustrating. It is demoralizing. I'm having more colleagues leaving the profession that I love because of that. And it's really, really sad. And we have to be creative in our outlets. My creativity just takes me halfway around the world.
Well, we're very, very blessed to have you join the practice, because I think what you're going to add, aside from what we talked about before in terms of that easier bridge for parents and kids to access mental health care, that's a huge part. But also, I think the enthusiasm and the love of what you do will definitely add to our programs, because we've been blessed with lucky clinicians, like a great staff, and I'm sure that you'll just add to it tremendously. So thank you for coming on board.
Thank you.
I'm appreciative as well, and look forward to our working together. And I know when we have our clinical meeting once a week, it's been a pleasure having your input and having you part of that.
Thank
and
you.
Both Andy and I have decided a long time ago that surrounding ourselves with younger people, as you can see, many of the clinicians in our group are young. It helps. It helps you continue to learn, because we're still learning, and also helps you to be a mentor to them. So
now that I'm 50,
thank you for being there. Yeah,
it really makes a difference.
Well, that's one of the reasons why I still teach at the medical school, because they will ask me a question that at one point in my career I knew, but I had to access it again, and some things have changed. So I really enjoy both being a preceptor and, being at the medical school. So,
well, but thank you very much for being here. And I'm Dr. David Gross, psychiatrist.
And I'm Dr. Andrew Rosen, psychologist. And this is Two Shrinks and a Mic, and we'll see you next time.
Bye-bye.
Dr. Moore. Thank you. The Two Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice. Please always consult a qualified healthcare provider before making any medical or wellness decisions. Our content is not a substitute for professional medical guidance, even though our mothers tell us we have the best advice possible.